Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. ACC AHA 2022 Guidelines for Cardiac Resynchronization Treatment or Therapy, commonly known as CRT, for heart failure. So let us find out who are the candidates for cardiac resynchronization treatment or therapy and what are the indications. Just to give you an overview of what is CRT, let's talk about what is CRT and what it does. Normally, when the heart activates, it activates the atria first, then it goes through the AV node for a delay for the atria to empty into the ventricles. Then we have the bundle of His and bundle branches which activate both ventricles at the same time. I want to emphasize the fact both ventricles squeeze at the same time. But when we put a single chamber pacemaker into the right ventricle, then the right ventricle is activated first, followed by the left ventricle. So there is dysynchronization of the ventricular contractions, which result in reduced cardiac performance. But by synchronizing the activation of the right and the left side of the ventricle to pump simultaneously, we can improve the cardiac performance by almost 20%. There are two ways to do it. More recently, people are putting a wire into the His bundle instead of the right ventricular cavity to activate the His bundle, which will activate the right and the left bundle branches simultaneously, so the right and the left ventricles contract simultaneously. The other option is to use three wires known as CRT, that is cardiac resynchronization treatment, which involves a lead in the atrium to activate both the atria at the same time. You can follow my green arrow here. We have the atrial lead which activates both the atria. Then we have a wire in the coronary sinus which activates the left ventricle, and we have a wire in the right ventricle which activates the right ventricle. So these two ventricles are activated simultaneously, which in many cases has been shown to improve the cardiac performance by almost 20%. So this is indicated in patients with severe heart failure who have certain electrocardiographic abnormalities, which we'll talk about in a minute. This is an elaborate procedure. It takes like 2-3 hours to perform, but it is definitely helpful in terms of symptomatic improvement of patients with advanced heart failure. As you can see, we also have some thick wires here, which indicates this is not only a dual or triple chamber pacemaker, it is also a defibrillator, because it has the capacity to defibrillate the heart in case the patient develops ventricular tachycardia or fibrillation. So now let's focus on what are the indications for a patient for a CRT treatment. We are talking about a patient with a heart failure who has been on maximum medical treatment for 3 months, who is over 40 days after an acute myocardial infarction. All these terms are extremely important, and if you are having a patient of this nature, all these things need to be documented in your medical record. This patient has been on maximum medical treatment for more than 3 months. The patient did not have a myocardial infarction or active myocardial ischemia in the first 40 days. Given that as the foundation, we look at comorbid conditions which have already been addressed for a year with guideline-directed medical therapy. And in these patients who have a reduced left ventricular ejection fraction that is less than 35%, then we have a New York Heart Association 1 with a left ventricular ejection fraction of less than 30%, a patient with a history of ischemic cardiomyopathy but no active ischemia going on at the time, a left bundle branch block with a QRS duration of greater than 150 milliseconds. That's a 2B indication for a CRT. But in patients with New York Heart Association classification 2 to 4, if the patient has a reduced ejection fraction less than 35%, a left bundle branch block with a QRS duration of greater than 150 milliseconds, that is a class 1 indication for placement of CRT. So let me crystallize this particular point. Class 1 indication is for someone who has been on maximum medical treatment for 3 months, who did not have a myocardial infarction in the past 40 days, who does not have any evidence of acute myocardial ischemia proven by like myocardial perfusion images, has all the comorbid conditions which have been addressed, along with left bundle branch block and a QRS duration of greater than 160, then that is the ideal candidate for placement of CRT. That this could be a bold question. If the person has all these above findings, and if it is not a left bundle branch block but just a non-specific QRS duration of 150 milliseconds, then it's a 2A indication. Similarly, a left bundle branch block between 120 and 149 milliseconds is a 2A indication for placement of CRT. If the person has no left bundle branch block and the QRS duration, when you're talking about wide QRS duration, we're talking about myocardial disease. That's why these patients are recommended to have not only CRT, in certain cases, even a defibrillator or ICD. So non-left bundle branch block 120 to 149 milliseconds, it's a 2B indication. Now let's look at some special circumstances. If a patient is in atrial fibrillation and right ventricular pacing frequently is anticipated, then what's going to happen is, first of all, you don't have atrial contraction. Number two, you're basically pacing the ventricle, which augments the dysynchronization of the ventricles, and in those patients it is a 2A indication to put the CRT. And in patients with normal sinus rhythm, if frequent right ventricular pacing is anticipated, this can easily be determined with an event monitor to see what percentage of the time the patient was pacing the ventricle. If it's like 60, 70, 80% of the time the pacemaker was pacing the ventricle, then you know that we have a significant right and left ventricular dyssynchrony for a persistent period of time, and those are the candidates for CRT. Whereas if the ejection fraction is 36 to 50% and the patient has high degree or complete heart block, that is a 2A indication for placement of CRT or cardiac resynchronization treatment or pacemaker placement, along with ICD if the ejection fraction is less than 35. If it's greater than 35, then we don't need an ICD, but it should be compatible with an ICD, because as the function gets worse, then we may have to replace the existing battery with one which can accommodate a defibrillator. Always remember, we have to rule out acute myocardial ischemia, in which case we may have to do a perfusion scan to show that there is no evidence of reversible myocardial ischemia, accounting for some of these findings like the ejection fraction and other parameters. So ladies and gentlemen, this is a very quick overview of what is the indication for CRT, what is CRT, and who are the candidates for CRT. Thank you so much for watching this presentation. I am Dr. Nik Nikam. I have an entire presentation on ACC AHA 2022 guidelines for the heart failure. It's a pretty long one, but it's a comprehensive review of heart failure guidelines for 2022 by ACC and AHA. Please watch that one and a series of other guideline presentations I have. Thank you so much, and I will see you in the next presentation.